Hi, I'm Mike Jumper, and we're going to be starting the pediatric panel. And the word pediatric in some language, I'm not sure which, means break. But I want everybody to know in this meeting that this pediatric panel is going to be something that almost any one of you might just see on any day, maybe next week. So keep that in mind. And with that in mind, I'd like to introduce our esteemed panel here. These are my financial disclosures. We have Besirli, we have Nagiel, Brittni Scruggs, Stewart, and Camila Ventura, an international and extremely knowledgeable panel with pediatric diseases. So these are going to be cases. I'm going to be asking them their thoughts and going over trying to hit the whole gamut of pediatric eye disease. So I'm going to start out with you, Jay. If you could just tell me, this is an 8-year-old boy with vision loss in his left eye for a month. You can see the right eye there with excellent vision and normal appearing fundus, and then his left eye shows a subhyaloid hemorrhage. He's had no trauma, full term, no medical problems. And tell me how you'd handle this.
Yeah, so I started thinking about the possible causes here. I think trauma, we know from published series in the past, by far and away is going to be the most common. More than 50%, maybe even 75% of these pediatric cases. And so even though there's no history of trauma, I think about trauma with this. Other causes in terms of congenital genetic conditions that can affect the vasculature and maybe cause leakage. Even hematologic conditions that might be there. I think we are sort of ruling out tumor, but want to keep that in the back of our minds as well. So in this case, I'd probably look again at the right eye and maybe scrutinize the photo for any kind of sign of vascular changes peripherally. We could think about doing an OCT or even an OCTA. Even macular OCTA can show microvascular changes that could be suggestive of something that might be going on in the other eye as well. And sort of think about whether maybe doing a hematologic simple kind of workup just to make sure there's nothing going on. But management-wise, I would probably start off with observation on this. A lot of these will clear up in the next sort of month or so, and then we can kind of see what's going on in the left eye.
All right, so Jay votes for MICO, and MICO stands for meticulous inactivity coupled with cat-like observation, which is an excellent plan. Brittni, this patient then goes on to have clearing of the blood over the first, just really 3 weeks, kind of a remarkable clearing of the blood. And then you see this. What are you thinking?
Yeah, so the macula has some dragging and some epiretinal membrane. You can see some exudates in the periphery and potentially some traction out in the periphery. So this is looking more like a fever-like picture, so a vitreoretinopathy. So I agree that I would want to look very closely at the other eye because likely there's a bilateral process. So I would want to do an angiography study and do a good peripheral exam.
Good. We took him to the OR for what we planned to do was an EUA and then probable treatment. So you can see here, shows no neovascularization in the right eye, but quite a bit of ischemia. And then this peripheral neovascularization in the left eye. Aaron, what's your workup at this point? What do you, and what would you do right now?
Yeah, so usually at the time of EUA, if I see this, I'll send for genetic testing with a large panel. We know that there are several genes that are implicated in fever, and unfortunately, they don't come back positive every time, even usually around 50% of the time. But I think it is helpful because then you can use that as a tool to test family members to see if they're at risk. But seeing this fluorescein, I definitely would take the opportunity to do laser treatment to the avascular retina in the right eye. I think this is your opportunity to prevent neovascularization and exudation and stabilize this eye.
So you'd do laser in the right eye at the same time as the UA and the laser to the left?
Correct.
Okay. And this indeed did have a couple of pathogenic mutations for fever genes in Frizzled-4 and LRP5. Yeah, so, and Aaron's answered that question. Let's move on. I'm going to ask Shavra if you can take this on. This is a 5-year-old boy who had a vision loss at screening at school. He's otherwise healthy. He does have a twin brother that has no vision or retinal problems, and his vision is 2400 in this right eye. How do you approach this? Really no secrets here. This is a kid with Coates disease and a lot of exudate.
Yeah, I mean, kid with Coates disease, with, like you said, a lot of subretinal fluid and exudate. So I think, my approach to that would be just, we want to act on it as quickly as possible. I would do an exam under anesthesia and make sure that, I look at the fluorescein and target the vessels that are leaking, also the avascular retina. And in this case, I think we really need to kind of worry about the lipid threatening the fovea. And for that one, I would start anti-VEGF treatment.
Okay, and then, so you're going to do laser at the time of the EUA and treatment, and then you're using anti-VEGF, not necessarily for the peripheral neovascular or avascular retina. You're using that to do what? What's the purpose?
Yeah, the role and the way I see this, the role of the anti-VEGF is not to treat the Coates disease, long term, but really it's almost a temporizing measure to prevent the lipid from settling in the fovea and causing vision loss while you're waiting for your laser to be, effective. Yep. So probably, anti-VEGF, and as you can, see here, you can tailor your treatment to the response. So in terms of frequency.
Yeah, and I have a strong feeling that this exudate is very attractive for neovascularization to occur, and an anti-VEGF at this time, while this organized exudate is there, can really decrease that chance of macular neovascularization that can occur. Camila, has this been your experience? How do you handle these?
Yeah, I like this approach very much. I would also associate a little bit of Subtine and triamcinolone. I find it helps also seize a little bit, calm down this eye. And also, a recent study by Eduardo Cunha in Brazil, he showed that laying the patient on the side of the affected eye has helped a few of his cases. So by putting the patient on the side of the affected eye, it would drain and not settle to the macula, So I will also advise my patients for that.
That's interesting. That's an interesting. In my opinion, it seems like the macular RPE activity is what really gets the exudate that direction. But that's an interesting concept. That's good. And so this is just the outcome over 7 years. I wanted to bring this up. I don't know if any on the panel would like to comment on this, but this is over an 8-year period of time, and it's just a reminder that we need to continue to screen these. Brittni, how often do you screen a patient that's had successfully treated Coates disease?
Yeah, so for a child who's actively being treated, I see them very frequently. So I do exams under anesthesia every few months, and I repeat angiography pretty frequently. Once I've treated successfully with laser and the exudation has calmed down, I then do exams every 4 to 6 months.
Yeah, you can see here in an area that previously looked very normal on the angiogram done in 2011, 8 years later, there's new changes consistent with Coates that needs to be treated again. So I think that, and there have been reports as long as 17 years after original treatment that new lesions have come available, and it is not unusual for me to see this. So Brittni, this is a patient that was provided to me by Eric Noodleman that has micropremie that at 35 weeks had been treated with laser for treatment requiring ROP, and now has been referred because of persistent activity. So how would you approach this if they're referred to you?
Yes, this ridge is very angry, right? It's an elevated, very highly vascular ridge. My practice is to definitely do injections first, so I very rarely get to the point where I've only done laser. So at this point, I'm doing an angiography. Likely there will be skip lesions and areas I could fill in. There's definitely some areas kind of towards the ridge that I could do some more laser. I likely would do laser plus injection in this case, but this is a very high risk case, so I would already start the discussion of counseling and potentially even evaluate the traction with OCT and start to talk about vitrectomy in the near future.
So Camila, a lot of the people in this audience, maybe they trained with ROP screenings where you do it every couple weeks. You didn't, think too much about the interval of screening, but how often are you going to follow somebody that you've just treated like this for their ROP?
Well, we're following this patient very closely for the high risk of detachment. Like we see here, it progressed, right, with detachment, 4A stage. So weekly, or if you're even thinking that it might detach even earlier than that, so very close.
Very quickly. And then this patient, then 2 weeks after that, that laser that was done, is now detaching and has the macula has remained attached, so they have a 4A stage ROP. And just wanted to kind of go over this briefly. This was Chadra provided this nice case that we're going to show the video of, and I have this graphic here just to show kind of the idea of the vectors that are involved with this very clear vitreous that you're going to go in and do a vitrectomy, but you're really just doing it in areas to try to break up vectors, as I understand it. Chadra, can you kind of talk us through what you're doing here?
Yeah, absolutely. So the schematic on the right you have is shows the problem, the retinal traction. So the traction is due to transvitreal forces from the ridge, and those go to the ridge to the nerve, ridge to the lens, ridge to ridge, and ridge to periphery. So we start with addressing the transvitreal forces, the ridge to nerve, and then once we address those with our vitrector, we're going to move to ridge to ridge traction. And we're doing this by sort of very carefully dissecting the membranes with the vitrector. And once the ridge to ridge traction is released, then we move on to ridge to ciliary body or lens right above the ridge. And then finally, we'll complete the surgery with addressing ridge to periphery. And the goal here is really different from adult retinal detachment surgery. The goal is not complete retinal detachment at the end of the case. The goal is to release the traction, and the eye will do the rest.
Thank you. One of the things that he pointed out that I forgot to point out was that the cannulas have spacers underneath them. Can you explain what the spacers are made of and why you do that? Yeah,
so there are two options. You can use adult cannulas, or you can use a pediatric, size cannulas. So if you don't have the pediatric size cannulas, you can use a scleral band, like a silicone, and use them as spacers to give you another, about 2 to 3 millimeters. So it shortens your trocar, and that allows more maneuverability of the instruments, and you can reach the periphery better. So as you saw in the beginning, the trocars are very close to the limbus, almost at the limbus, which really kind of limits your ability to remove those instruments. So having shorter trocars are helpful.
Anything else, Aaron?
Well, yeah, one other trick that Tom Lee taught me is actually these cases where it's mostly temporal traction and very anterior, you can sit temporally, and it gives you a lot better access to the traction, so you don't have to cross over the lens in these cases.
These are great points. Moving forward, this is what everybody in the audience can see and will see, is an 18-year-old, former 25-week gestational age, who's been followed annually after treatment for ROP. So, Jay, tell me what you see and what you think in this kind of a case.
Yeah, I mean, I think the concern is that these post-preemie kids, as they get older, we know that a certain percentage of them are going to have vitreous, contraction out peripherally near the area of prior laser, prior cryo. And so probably about 5% or so of them are going to get detachments and tractional elevations into their teens, and that's been reported out, 10 years or more past treatment. So I think, I look at these people annually, and I get photos just like this, and I kind of put the photos side by side, year by year, and just sort of see if we see any changes. Sometimes we'll get OCTs looking peripherally as well.
And Brittni, you've published on this in kids who were former preemies and had ROP, maybe didn't even receive treatment. What are we looking at as far as their avascular retina, and what have you seen in your studies?
Yeah, so we know that PAR, peripheral avascular retina, is really common now in the anti-VEGF era, where kids are getting injections and then they have significant PAR. So we wanted to study spontaneously regressed ROP, where these children did not get treatment. And what we found was over 90% of those children ended up having significant avascular retina, and 30% of the cohort had PAR within zone 2.
Yeah, so
pretty significant. And time will tell, but potentially that's a high risk for late detachments, which,
right. So I think wide field angiography, if you're considering studying angiography on an adult who had ROP, wide field angiography is important to kind of look for this and maybe address it. And I just pointed out that this is Chadra's patient, but I put in some little arrows here showing where it looks to me like the vitreous is kind of wanting to pull up. And indeed, this patient did have sort of late onset traction. And Charter, can you comment on this, that what you have seen and you've reported, you gave me some of this nice slide.
Yeah, these patients sometimes, as you mentioned, you can identify those areas at risk, and when you follow them, up to about 30% of them will actually have these vitreous condensation, almost forms like a new ridge. And in this patient, there's a very taut posterior membrane causing retinal traction. So this is when you're worried about tractional detachment and VMT, and this is a case where I think surgical intervention is something that you would discuss with the patient.
And this is a case that, Jay, I want you to comment on this, Jay. This is a really sudden onset vision loss in a former ROP child, and it brings up this same issue with the vitreous. So I'm gonna start this video, and Jay, you can kind of talk us through it.
Yeah, so this is a post-laser patient, sudden RD onset, and not immediately obvious where the break was, but we suspect it to be a slit break at the edge of the prior laser. And so most of the work here is kind of get the hyaloid off, and you take it out as far as you can. There's usually a tight adherence there, and then we did find the break at the edge of the laser. And then, we usually will supplement that laser basically 360, and then we also put a buckle and oil. And I think just, you really can't get the hyaloid out all the way to the very edge of that laser, but you try to get it out as far as you can. That really resolves the problem.
Yeah, and a plug for intraocular triamcinolone in those cases to be able to identify that very wispy hyaloid, but will cause you great problems if you don't get it up. So this is a case that was provided to us by Camila, and I'm going to ask Aaron to comment on this. This is a 3-month-old, born full term. And has these macular changes.
Yeah, so these look like lacunae, less like colobomas. So I'm thinking a CARD or Zika, or maybe an atypical toxo infection. So definitely right off the bat, looking for, asking the patient whether they're born in asking the mother if they're born in an endemic area for Zika, microcephaly.
And asking your moderator whether Camila provided it or not.
Yeah, right. That's a big clue. Yeah.
That helps. So so this is a case of this mother denies rash, fever, arthralgias during pregnancy, but the baby has severe microcephaly, and that is kind of one of the telltale signs of congenital Zika virus infection, and this patient had a positive IgM for that. And 21 months later, Camila, can you comment on this? Has there been progression of these scars, and can you kind of tell us about the natural history of these patients, which most of us have not seen?
Yes, so we don't talk much more about Zika, but it has, we have reported Zika in 89 countries. So in the US, you had cases of congenital Zika syndrome. What we know now is that 5% of the babies that were exposed to Zika intrauterus, they have the birth defects, so they have congenital Zika. And out of these, 1/3 of them will present fundus findings, as we see here. So what we're doing now, we are studying these eyes over time, and we're measuring these scars and seeing that these lesions are actually enlarging with time, and some of them are pigmenting more over time, as we can see. The optic nerve also, the disc cupping has been increased over time as well. So this is something that we are reporting in the literature soon.
Camila, do you often get brain imaging? Because I know you can have cerebral findings. Does that impact the vision ever?
Yes, for sure. So regardless of having ocular findings, as we see here, most of these children present visual impairment, and most likely this is related to the brain damage. So brain imaging, MRIs, are super important in these cases, and we're looking for subcortical calcifications that are very specific of Zika and different from the calcifications that we see in toxo and CMV. So it does help a lot when we're studying these children and investigating the cause of these findings.
Perfect, thank you. Last case here, I'm going to ask Brittni to describe what she sees and venture a guess on this 7-year-old with decreased vision in the right eye, 2400 vision.
Okay, so the macula has pretty striking area juxtafoveally that has whitening and thickening. It looks like an acute infectious retinitis, so I would be very concerned in the 7-year-old if they have something like toxoplasmosis, and I'd want serologies.
Do you start treating right off the bat and then kind of as you're getting the serologies when it's this close to the fovea?
It's a good question. I would probably get serologies. This is a high-risk case, right, because it's affecting the vision. This patient is young, and once you start treatment, serologies are potentially affected, especially if you're getting aqueous. So I would probably do everything at once. I would do an exam under anesthesia, I would get an AC tap, I would get blood draw, and I would start treatment all at once.
And Camila, how do you treat these? Now we know the IgG is positive for toxo. It looks like there's a toxo scar in the other eye. I think you can presumptively treat for that. What treatment do you use?
Yeah, for these kids, 7-year-old, we can do the typical traditional treatment, but for this case in specific, we did Bactrim. And we associated steroids, oral steroid, and I find that once it's very close to the macula, it can affect drastically the vision of this child. I try to pair with the pediatrician so that I can do a little bit more of steroid and not only 0.5 milligrams. So I tend to do 1 milligram per kilo a day. And we had a great visual result in this case. We actually don't wait for serology. Brazil is endemic for toxo, so 80% of patients of the population in some regions of Brazil are IgG positive already. So when we see a very typical lesion, as we saw in this case, we start treatment. And we say that toxo is guilty unless proven innocent, so that's why.
Well, listen, we're leaving it on a high note with 20/40 vision. I want to thank all of our panelists, and thank you for your attention. Great job. Thank you so much. Thank you.
I want you to come back because there's artificial intelligence, there's a session on surgery, and then closing with surgical videos. So please go and get a break, have a little break, but in 30 minutes at 3:40, we need you back. Thank you.